Okay, I'm going to go ahead and introduce our guest today. Welcome to Medicine Grand Rounds this March the 12th. I am super excited to have actually a very distinguished guest today in Dr. Renee Salas. Dr. Salas is a well-recognized expert in climate change and its impact on health, healthcare, and equity, which is an area where there is a lot of interest at Emory. She is an emergency medicine physician in the Center for Social Justice and Health Equity in the Department of Emergency Medicine at MGH and Harvard Medical School, and also holds a variety of appointments at Harvard, including in the Harvard Global Health Institute, the Center for Climate, Health, and the Global Environment, and the Global Health and Social Medicine programs. She received her MD from the 5-year medical school program, which is at the Cleveland Clinic Lerner College of Medicine, launched like 15 years ago, I think, 20 years ago, something like that, and got an MSCR from the Case Western Reserve University School of Medicine. Her MPH is from the Chan School of Public Health at Harvard with a concentration in environmental health. She engages in research to explore how climate change is impacting the healthcare system and serves on committees at the nexus of climate change and health nationally and internationally, and has received numerous awards and recognitions for her contributions in this important area. In addition, she's a guest editor for the New England Journal's Fossil Fuel Pollution and Climate Change series, and is co-director of the New England Journal Group Climate Crisis and Clinical Practice Initiative. She's a member of the Global Lancet Countdown on Health and Climate Change, and is the lead author of the U.S. Brief between 2018 to 2021, moving to senior author in 2022, and founded and leads the U.S. Brief working group of over 80 U.S. organizations. She was recognized for really this critically important work with election to the National Academy of Medicine in 2021, and is on the steering committee for the NAM Grand Challenges on Climate Change, Health, and Equity. She also has testified in front of Congress and has for the Full House Committee on Oversight and Reform, and presented at the White House Health Equity Forum. I think clear to say that she, I think, is probably the leading expert in climate change and health at this point. And so we are incredibly honored to have you join, and so grateful that you've taken your time out to do.
I was going to say, how are you going to do climate change in?
So welcome, Dr. Salas, and thanks.
Well, thank you so much for that overly generous introduction. I always say you can just say my name and I'll just jump right in. But thank you. It is such an honor and privilege to be here. So thank you, Dr. Armstrong, for the invitation, and to Dr. Del Rio. As I was having some conversations, I have so many people that I am fans of and really admire the work at Emory. And so it's an honor and privilege to be here. And I really view this as being hopefully the start of a conversation. So I, first off, always have to double check. Do you guys see the full slides?
We do, yes. Perfect.
Perfect. All right. You never want to have that situation where you're sharing the other side and you're seeing what the next slide is. So I always want to double check. So we, I understand that there are trainees, as always, sort of in the audience. And I love the format that you guys have to really share some of my journey in the first couple minutes. And so to all of those people out there, I appreciate Dr. Armstrong highlighting where I started back at the Cleveland Clinic Lerner College. But just to share that I thought I was going to be an oncologist and lead clinical trials. So needless to say, as you heard how I've been spending the years of my career thus far, it is far different than anything I ever imagined. And I just really want to highlight that for me at each phase and decision point that I needed to make, I really followed where my passion and calling was, not knowing where it was going to lead me. So, and to be honest, I had people try to talk me out of it because oftentimes I was stepping into areas that were not well established or even arguably established at all. And that process led me to where I am today, and I wouldn't change anything about it. So if there is something that gets you out of bed in the morning, that when you see headlines about it, you dive into that topic, And you just, it is that passionate call to your soul. Listen to that. And even if what you think you want to do with your career doesn't exist, that is an opportunity to carve out an area. And I have seen where trainees are able to carve out areas in arguably perhaps the most impactful way, because they can bring together different faculty that have that multidisciplinary expertise and complementary skill sets to really carve out so many of the novel approaches that we need in order to transform our system to improve health, save lives, and advance equity. So don't let anyone tell you not to do something because it doesn't exist. Find a way to make it happen. And fellowships are a great way with which to do that. It allows you to bring in sort of a multidisciplinary team, having department chairs and other individuals in leadership who are willing to support some of these novel areas. I can say, at least within this field of climate change, health equity, and healthcare, that there are numerous areas that we need advanced, and we need them across all specialties in all regions. And that is to hint at sort of some forthcoming work. We want to really accelerate that process. So with that said, this is actually a photo I took, arguably feels like 7 lifetimes ago, but from the top of Mount Kilimanjaro. I do not get out in the mountains anymore, but there was a period of my life where I did. And yeah, so whatever it is that excites you and whatever vision it is that you have, chase it. That said, this is a grand round, so we have to have learning objectives that we are going to target today. And so here are 3 of them that I hope that you can walk away feeling equipped with. So recognizing how fossil fuels is the primary driver of air pollution and climate change, identifying how the burning of fossil fuels threatens the mission and practice of medicine, and then learning the actions you take, such as applying a climate change lens to your practice. And I would challenge each and every one of you to at least find one thing that you could walk away and do today. There is no thing that is too small. You got to take that first step. So let's dive into tackling those 3 interconnected areas. So in emergency medicine, it is often my quest to find that primary diagnosis. What is it that brought the patient into the emergency department in the first place? Unlike your specialty where you are able to, and I think necessitates you listing out secondary diagnoses, or just those things that make it harder to treat or manage the primary diagnosis, whether we're thinking about hyperlipidemia for coronary artery disease, hypertension, et cetera. We don't often think about those secondary diagnoses, but my journey and that has led me especially to this work has forced me to think about those secondary diagnoses. So one patient I'd like to share that has stayed with me was an elderly gentleman whose wife called 911 because he was acting confused. And the EMS crew, who I knew well at that point, said that they climbed up to the top floor of the patient's apartment, or the patient's building, to get to the patient's apartment. And they said that when they opened the door, they were hit with heat that felt like they were in the Sahara Desert. Now, this couple, during what at that time was record-breaking Boston heat, did not have air conditioning or any cooling mechanism, and only had a window that was partially cracked. And so they, at that point, the patient had shown that they had a fever at triage. And so we quickly transferred them with that history onto the stretcher and got a rectal temperature, which showed a rectal temperature of 106 degrees Fahrenheit. Now, any board question out there, I think you all would select the primary diagnosis is heat stroke. But I would argue that a secondary diagnosis, so something that was making it harder for us to prevent heat stroke, is climate change. And in fact, there was a landmark study that was published within the past few years that showed that more than 1/3 of urban heat-related mortality is attributable to climate change between 1991 and 2018, so over those 2 decades. And arguably, unfortunately, we know that temperatures have continued to rise since then. And there's a second case. There was a young girl who came in struggling to breathe, and it was her third visit that week for an asthma exacerbation. I'll never forget those. We all have those moments, right, that you just don't ever forget. But the patient's mother looked at me as we were giving the patient nebulizers and connecting her up to monitors. And she said, "Doctor, I have done everything that the doctors and her treatment teams have told me to do, and she just keeps getting worse. What am I missing?" Long after they had gone upstairs to their hospital bed, after my shift, I was looking back through the patient's chart, and sure enough, every one of her treatment teams were following evidence-based guidelines, but she did just keep getting worse, and we saw increasing visits. So I looked up the patient's address, and she lived in a previously red-line neighborhood in Greater Boston that was directly next to a major highway. In addition, we had been experiencing record heat and pollen in the springtime, and it has been shown that pollen levels have increased concentrations and duration because of climate change. And heat produces ground level ozone, which is produced from the combustion products of burning fossil fuels. So all of this was combining to make a perfect storm that was making it impossible for that mother to protect her daughter, for that patient to be able to manage her disease. And I just had that feeling that I was putting Band-Aids on bullet wounds, that I was not able to actually get to the root cause of the problem, but we were giving her medications and then sending her back out to that same environment that made it impossible to manage her disease. Oftentimes in the emergency department, I feel like I'm pulling patients out of a river one at a time, only to see so many behind them. And so it's only when we run upstream to find out what is causing these patients to fall into the river in the first place that we can get to the root cause. And as we run upstream for so many problems, we find that the burning of fossil fuels is either directly contributing or indirectly contributing to diseases and pathology. So when you burn fossil fuels, you'll see it sort of at the bottom of this figure, it produces a whole host of air pollution. And you can see on the far right that nitric oxide and volatile organic compounds that are produced when we burn gas in our cars in the presence of heat and sunlight produce ground level ozone, which is known to exacerbate especially pediatric asthma. There's also a host of other, and particulate matter you see on the far left is arguably one of the best studied air pollution components. But all of it shows that in 2019 that 99% of the world's population lived in locations with air quality above the World Health Organization standards. That includes here places in the US. But of course, those communities that are experiencing air pollution to a disproportionate degree are not by accident. But there's upstream systemic, structural, and environmental racism and economic injustice that determines who gets health protective parks in their neighborhood and who gets highways and polluting industry. There have been numerous studies at this point, but here is just one that shows that air pollution disproportionately impacts people of color in the US. Now, purple are those individuals that are people of color, and green or white. And you see that they look at state averages and sort of the percent exposure from disproportionately exposing source types. And you'll see that the purple dots are all above that line, showing that they're more exposed. But what does that mean for us at the bedside? Well, in fact, it has been shown that long-term exposure to air pollution, especially from vehicles burning fossil fuels, causes asthma in children. And in fact, it's been estimated that for NO2, at least, it causes 1 in 5. Now, causality for us is the holy grail. It allows us to actually get to the root cause and prevent the disease from ever happening. But there's also implications for adults as well, as air pollution has been shown to cause heart disease and death. And in fact, the American Heart Association determined that well over a decade ago. And in fact, air pollution has been linked to nearly 9 million premature deaths globally, in addition to being associated with a host of other diseases that you see listed here. So all of that means that there is an opportunity to address this host of morbidity and mortality through a transition away from fossil fuels to renewable energy. Because the burning of fossil fuels are also the primary driver of climate change. And burning of fossil fuels, in fact, accounted for 92% of US human-caused CO2 emissions in 2020. Now, climate change is a complicated phenomenon, but there are some simple ways in which we can think about capturing that and understanding that. And I think for one thing, and this is an analogy that a colleague of mine, Dr. Katharine Hayhoe, uses, but she says when we think about extreme weather, that it loads the dice. And so it's more likely that we are going to get intensified extreme weather that is out of our normal cadence that at least I experienced growing up. In addition, we think about it as global weirding. It's another term that she uses as a climate scientist, and I like it because I think all of us can probably point to circumstances that we've experienced personally where weather is just weird. And weather can be weird. Again, that's the short-term experiences of our temperatures and precipitation, et cetera. But then there's also the long-term trends with climate. And so there was an update just in December of 2023 to understand where is it that we are when we think about the pre-industrial baseline. So before we started burning fossil fuels and putting them into the atmosphere. So that's that pre-industrial level you see at the bottom of the thermometer. Now, you guys have probably all heard about the Paris Agreement, and that is arguably the world's largest public health agreement. But the goal of that agreement, ambitiously, was to keep warming below 1.5 degrees Celsius. But we are currently, and there's varying estimates, but we are in the range of 1.3 degrees Celsius warming right now in 2023. So you hear about all the pledges that are happening, and I know there's action that's unfolding, which is fantastic. We need to accelerate that, and we in the health sector have an especially powerful platform with which to do that. And so if you look, though, at policies and action that have currently happened, you'll see that that puts us somewhere on target of 2.7 degrees Celsius. And then you also look at sort of even the optimistic scenario puts us at 1.8 with, again, some ranges that occur there. So needless to say, we don't have the interventions we need yet to keep us below the Paris Agreement goal. And it is now questionable if we will be able to obtain that. There's also a 66% likelihood that the annual average near surface global temperature, so that's just that 1.3 degrees Celsius, in the next 5 years is likely to at least transiently go above 1.5 degrees Celsius. And this summer is unfortunately expected to have even more record-breaking heat as we have some collision of different factors climate-wise, including El Nino, which is the normal variation on top of now and supercharging climate change, which has been unfolding. And so this is a figure that I think is helpful as we think about anytime you see climate diagrams, dark red or dark colors are usually heat and really bad. So you'll notice you can sort of find when you were born and reflect the experience that you saw and experienced climate-wise, and then sort of that which we will experience in the future, and those especially of children and thinking about intergenerational justice, what their future is anticipated to look like. But again, we have an opportunity to change that and make us on the very low emissions pathway, which is that bottom line after 2020. Because there are a lot of hopeful signs, and in fact, renewable energy surpassed coal and nuclear in the US in 2022. And the Infrastructure Reduction Act also hopefully is catalyzing us towards reaching goals that are somewhere in the range of 40 to 45% of our previous baseline. Unfortunately, though, if you look at the compatibility of oil and gas company strategies with the Paris Agreement, and this is data from the Global Lancet Countdown report, it is putting us far off track. So they are continuing to pull fossil fuels out of the ground and burn them, again, leading to not only the air pollution and other pollutions across its extraction and production line, but also driving climate change, which we're going to be diving into even more. And climate change ultimately acts as what I like to think of as a threat multiplier and a meta problem, just meaning that it underlies other problems and makes them worse. And that concept is especially poignant as we think about existing healthcare infrastructure challenges, or thinking about the health disparities from structural racism and economic injustice that is just making all of those worse while also causing new disease. So if we think about, we've covered the fossil fuel extraction, processing, and combustion. Again, there's pollution across that entire spectrum. And the fossil fuel pollution that I highlighted most was talking about air pollution. We still need to really better understand and accelerate the research, which I'll talk about, around the other polluting sources. But it's also driving the increased greenhouse gases, which is leading to higher temperatures, more extreme weather, rising sea levels, and sort of a range of pathways through which is causing disease and exacerbating existing disease. So we think about heat, we think about air quality, as I highlighted in my patients, with increased pollen levels, wildfire smoke, which are more intense as a result of climate change. There's food impacts, so actually making crops less nutritious of vital nutrients, which is especially important for those populations that are already on the nutritional margin and can challenge our food supply. So being able to grow the food we need, in addition to thinking about transport challenges. We think about our water supply. And so in fact, the major causes of waterborne gastroenteritis, all of them are climate sensitive in some way. We also think about Vibrio, which of course causes gastroenteritis and soft tissue infections, and that thrives on warm ocean waters. And so we've seen that, especially in my area in Boston and in New England and the Northeast, increasing in concentration, and thus patients are more likely to be exposed. And then also thinking about the intensification of extreme weather, that vector-borne diseases can be transmitted more because the mosquitoes and ticks, they are able to survive and thrive in environments for a longer period of time, allowing them to transmit diseases like Lyme or West Nile, or we think about malaria and dengue, which are also starting to make resurgences here in the US. And then we think about the social factors. And so the social interconnectedness, whether that is displacement from your home, both within one's country, or displacement across borders. And then it also impacts healthcare delivery, which I will dive into as well. Now, all of these different categories of vulnerability, I like to think about it in 3 buckets. So there's susceptibility, so having an underlying aspect or characteristic of yourself that makes you more prone to experiencing these climate-related risks. And so that can be due to age, thinking about the old and the young, thinking about people who have underlying medical problems, thinking about exposure. So those, for example, in occupations that are more likely to be exposed to hot temperatures, outdoor workers are a key example. Or again, those who live in previously redlined areas and are more exposed to urban heat islands, which have been shown to be more prominent in previously redlined areas. And anyone who has stood in the middle of a parking lot on concrete or under a shaded park can clearly feel firsthand why there can be, sometimes 7 to 20 degrees difference in those different environments. And then, of course, one's ability to adapt. So having the resources with which to weatherize your home, install air filtration systems, and have health insurance, which I argue is a key adaptation as we think about what's needed to protect populations from climate change. But geography is also a varying factor in the US, especially as you think about the different ways that these climate exposure pathways actually impact different regions, which gives us a really profound opportunity to learn from one another in order to accelerate our understanding and address multiple issues as people experience different aspects. So those in the South, they're used to having hot temperatures. I think you can be key examples of that. And in fact, there was a study in 2019 that looked to see at what heat index ranges do peak hospitalizations occur. And you'll see that there's all causes, and then they break them down into categories like cardiovascular, respiratory, diabetes, fluid and electrolyte, and renal failure. And the gray line that's on that bar highlights when the heat alerts go out. And so those heat alerts are occurring sort of before, in the South, are occurring before the peak hospitalizations occur, which are sort of those checkered bars. But you'll see that's happening at somewhere in the range of, 105 degree Fahrenheit heat index. But when you look at the West, you'll see that it's actually 81 degrees Fahrenheit is when peak hospitalizations occur. And I think anyone who's lived in those regions sort of recognizes they're not used to experiencing those types of extreme heat temperatures. And so they don't have the behavioral and educational knowledge to know how to operate within that. They're not physiologically adapted, and they don't have the infrastructure like the air conditioner penetrance within households in order to equip and protect them. But you'll also note that the gray line, and so when the public health notifications or heat alerts were going out, was actually well after peak hospitalizations were already occurring. And this really shows the power of research, because this and sort of other work has helped catalyze certain regions that have adjusted their heat alerts in order to ensure that they're targeting the right populations at the right temperatures to prevent harm. So that gets me to research. Do we have the research we need? And I can clearly say we do not. We have a lot of research that shows, especially around heat, and we definitely know the problems exist. But as we think about the solutions that are needed and the actions we need to take, we need a plethora of more research to really understand how to best implement and protect populations. So we did a study that was published the end of last year in order to try to characterize exactly how much extramural U.S. federal grants were targeting climate change and health. And we defined that very narrowly in the aspect of how we would use that within, for example, clinical practice and public health. And so we screened grants and actually had a bunch of reviewers that were screening them. We had 102 grants that met our inclusion criteria. And it showed that the total award value during this 11-year time period, and we went 2010 to 2020, was $58.7 million, or only about $5.3 million per year. And the majority that were awarded was through NIH. And if you look at the distribution of these grants, we found that most awards came from HHS, with NIH being the largest awarding sub-agency within HHS. And then you'll see, and you can, if you want to dive into the details, you can sort of dig into where the rest of the money went. And we actually also highlighted where the recipients were. And so if you look at the variance, here's kind of the variance over time. And so you see that there is increasing, at least within the, starting to look at 2017 to 2020. And there, of course, has been subsequent work even since 2020 with the creation of the CAFE, or the NIH Climate Change and Health Community of Practice Grant, which was awarded to Boston University and the Harvard School of Public Health. And so there's definitely more work happening, but we have to accelerate it COVID style. We've shown that we can take and mobilize the data needed when there's motivation, resources, and collaboration, and we need to do the same for climate change. And arguably, if you look here to see kind of what were the most funded topics, you'll see that there's climate sensitive exposures around extreme heat, hurricanes, wildfires, climate sensitive health outcomes. You'll see those listed there were the ones that were the number of grants that targeted those. And then populations of concern, non-specific, which of course, some of these grants didn't specify. Children and pregnant people were the most common, but notably there was no funding awards that were identified focused on Indigenous communities or incarcerated populations. So we have some recommendations there on what that means and have had subsequent conversations with federal partners since. But that means that we need to leverage our existing research infrastructure to help answer these questions while we mobilize the resources needed. And then kind of the last big category I want to talk about is thinking about how climate change is impacting healthcare delivery today, and recognizing that this is, can you guys still see?
We just lost your slides.
Worried that was going to happen. Well, we needed a little intermission. There you go. All right, let's see what happened here. The back?
Not yet. We've got the has started screen sharing. There it is.
Okay. Oh, there we go. All right, there we go. Let's see, it's halfway through. I think my computer knew we needed to do a little half an hour break. Everyone can sort of stand, shake it out. All right, perfect. So we did a survey of over 500 US healthcare institutions and leaders, and 75% reported that climate change was impacting healthcare delivery today, which was arguably probably lower than in fact is true, at least from my personal beliefs and assessment, because I think healthcare delivery is impacted 100% of the time in different ways, whether we think about the supply chains and shortages, thinking about the intensification of extreme weather, which leads to infrastructure damage and power outages and inability to provide care that's needed at the time that it is required. And then, of course, thinking about how that's impacting your patients and their ability to provide high quality clinical care, especially to those that are most impacted. So a lot of these are indirect and insidious. And if you look at sort of their responses, I think they were arguably on the lower end of recognition. But it does deliver, climate change does threaten the delivery of high quality healthcare. And there's emerging evidence to support that. For example, there's one study that looked at the lung cancer patients whose radiation was interrupted because of a hurricane. And we know that climate change is making hurricanes stronger, wetter, and faster. And so that showed that those that had interruptions died sooner. And so you can have the best oncology treatments for your patients, but if they can't actually access their care at the hospital, then that is our inability to deliver the high quality care that we aspire to. We had some recent work that just came out, I think about 2 weeks ago, that was published in Nature Medicine, and that looked at billion-dollar weather and climate disasters. So these are the biggest events that are occurring across the US. There's 7 different categories that the federal government tracks, and that includes tropical cyclones, hurricanes, severe storms, floods, wildfires, droughts, and freeze events. So wildfires and droughts obviously are very different types of events with different mechanisms of harm, especially as you think about wildfire smoke traveling across the country. And New York City, in fact, had some record air pollution as a result of wildfires in Canada and in the northern US. So we are all interconnected. And so we didn't look at those because they often lasted kind of 200 to 300 days. And then there were no freeze events during our time period that we looked at, which was 2011 to 2016. So focusing in on the billion-dollar disasters that include severe storms, wildfires, winter storms, and floods, make sure I get the list right. 65% of counties were affected by at least one of those disasters during this time period. And you'll see that the South was one of the harder hit areas. So we looked at emergency department visits, hospitalizations, and mortality in Medicare beneficiaries following exposure to these. And we used the economic impact, so property and crop loss, as our common denominator to be able to compare apples to apples across those events, because that's arguably how we prepare both our healthcare systems. We have to be prepared for multiple different types of events. And so we did a difference in differences approach, and we found that in the first week after these events, that ED visits and mortality were both elevated. Interestingly, hospitalizations were unchanged. And I think that is because we have multiple factors. I think there's a really complex interplay unfolding, and work on tropical cyclone shows that some increase, some diagnoses for hospital admissions increase while others decrease. So if we're summing them, we could see no change. There's a lot of other theories, but that's a whole talk in and of itself. So happy to dive into it for anyone interested. We also kind of outline it more in the paper. But we then also looked at extended time periods. And so I know this is a little bit small. You can kind of focus on the right of this forest plot. And this looks at mortality in the 1 to 2 weeks, which is the first line for the overall, which is so I would just focusing on kind of the first 2 lines here. And then the next 4 weeks, so looking at weeks 3 through 6. And so you'll see that mortality actually was highest across the whole 6 weeks of our study period for severe storms, which to our knowledge hadn't been looked at within Medicare beneficiaries. And then this looks at ED visits and similarly sort of shows that increase within the first 2 weeks, but you'll see there's quite some variation across different categories of events, which is not unexpected given the different mechanisms that they have. We also then look to see what was the difference for top quartile counties, so those that were most damaged. And you'll see here that for ED visits, the most damaged within week 1 had almost a little 2.5 increase in mortality. Similarly, was nearly a 2-fold increase within the most impacted. Now, again, you're probably thinking that's not surprise. Those counties that had the most property and crop loss, thus the hardest hit, will have the highest mortality in ED visits in week 1. But I think the surprising aspect of our work showed that this extended all the way out, even to weeks. And this actually this actually should be time period 1, 2, and 3. So what says week 3 here is actually weeks 3 through 6. And then the second one is weeks 1 through 2. But you'll see that they remain elevated in these counties, and again, are upwards of 3 to 4 times higher in those longer time periods than when we looked at all affected counties. So these are having really long-lasting impacts. And we have to better understand what is happening to these patients. Is it the disruption within the healthcare system itself and sort of that societal disruption? And it's probably thinking about some of the mechanism that these storms cause prolonged harm, whether we think about development of allergens in flooded homes long after the water recedes. Those patients, especially those with underlying respiratory conditions, for example, are prone to that. Whew. All right. So that was a lot, but wanted to make sure and share sort of some of the evidence and data that exists to provide just a sampling of the challenges that we have. But I'm more optimistic than ever that we can tackle this. And so I don't want anyone to be slumping in their chair saying, oh my gosh, we can't do this. Because in my mind, the fact that all of these things are interconnected, that we can actually address the air pollution, morbidity, and mortality through a treatment for climate change, which is renewable energy, and the fact that the populations disproportionately harmed are those that suffers from environmental racism and economic injustice. All of these are intertwined, and these interconnected challenges can facilitate interconnected solutions that can allow us to tackle all of them at once. Because reality is that we have to start doing some things differently. I think anyone, and I know all of us that work within the health sector, have not been able to ignore the recent life expectancy in the US. And of course, this shows that we have downtrended. And while other countries have been able to rebound after COVID, we have not shared that same rebound. And as you see, we're also have been below comparable country averages. Now, this study it's a bit older, and it has its I think it's methodological complications, but it's a really hard thing to try to tackle. But I think it just provides a really good framing for thinking about that what we do in clinical care, which you see here is kind of 20% of what leads to health outcomes like length of life and quality of life. And in fact, they estimate that health behaviors is about 30% and social determinants of health is 50%. And I argue that all of these things are impacted by fossil fuel pollution and climate change. And so there's already been so much work seeking to try to address both our physical environment, our social and economic factors, and health behaviors. But we have to start accelerating our engagement across this whole continuum if we really want to extend that length of life as just one metric of many that are important to our patients. So we're no longer putting Band-Aids on bullet wounds. So the New England Journal of Medicine, they launched a series in June of 2022. And in the editorial that we launched we said that the series aligns with our core mission of equipping physicians and trainees with the knowledge and tools required to practice in the 21st century. So this is relevant to what we do every day, and we have to start incorporating it, but arguably making it easy for you to incorporate it, integrating into your Epic, and facilitating all of these things seamlessly, which can happen as if we can think of something, and I'm a photographer, don't do it so much anymore, but as a hobby, but adding a climate lens, which anyone can, whether you wear glasses or otherwise, a lens just means viewing whatever it is that you're doing, both through a climate lens that understands how are fossil fuel pollution and climate change impacting that aspect now, and how will it do so in the future. So we have to get upstream. But I'm going to focus first sort of on the clinical practice aspect, and recognizing that while there are oftentimes a perceived barrier between sort of public health and community and population level interventions and individual interventions within clinical practice, we have to break down that system. And we all work within sort of the larger health system, or at least within medicine, kind of traditionally the healthcare system. So how can we adapt those aspects, seamlessly work together to integrate both population and individual level interventions within a resilient healthcare system? No small challenge, but I know we're up to the task. So breaking down those barriers, and of course, as we think about those aspects, there are going to be themes that resonate across the United States. So independent of where it is you practice, what climate exposure pathways you experience, based off where you live, what your specialty is, what type of patients you see, and your local healthcare infrastructure will all determine and factor into how this impacts your clinical practice and how a climate lens will be added to them. And of course, there's multiple places, and so I sort of can, frame it within some of these larger buckets. But if you think about, for example, my patient that I described earlier with heat stroke, so he came to my emergency department and had a fever. Now, if he had been sitting in an air-conditioned apartment and was confused, then he probably may have had urosepsis, a true fever from an infectious pathology or infectious agent, and was having some associated delirium with it. However, when we have temperatures that are above that threshold that I showed you based off your region, where the heat index is such that patients are likely to develop heat stroke or heat-related illness, what if there was a Epic best practice that popped up to ask the triage nurse in the emergency department to ask that follow-up question about heat exposure? Now, it was very clear the EMS crew told us very quickly that that patient was sitting in extreme heat, which made heat stroke kind of diagnoses 1 through 20. Now, that is a time-sensitive diagnosis, and so that patient should have gone to our most acute area of the emergency department. We quickly moved him there, but you can imagine on a busy emergency department shift where I wasn't able to be at the bedside, that patient may not have gotten that immediate treatment they needed. And these are hence just sort of small changes, but recognizing that these are things that can save lives, but are best implemented when integrated within the system. Thinking about triage and being, especially, again, my framework is from emergency medicine, and I have no doubt all of you would be able to provide critical insights within your own specialty, which is why we need to facilitate and accelerate these conversations. But thinking about triage questions that could be asked. In the emergency department, oftentimes we are the ones that are encountering our patients during the heat wave. And we can tell them to follow up with their primary care physician in internal medicine or family medicine, but oftentimes they won't be able to see you until that heat wave is well over. And so how can we ask them if they have health protective cooling? Just having air conditioning is not enough. And there have been so many stories and research studies that have shown that patients can die in their home with an air conditioner sitting there. They may either not be able to run it and afford to run it at the level that is required for health protective cooling. And so how can we get to the heart of those questions that really matter and then guide them on the resources? And should we think about heat pumps and income-based subsidies for energy, the same way we think about that during the winter. And arguably, as we experience more extreme heat, we need to start thinking about that as a health intervention in order to prevent our patients from ending up in the emergency department to beginning. Thinking about patient screening and certain medications that they're on, we know certain medications make patients more at risk for heat-related illness. And so for those that have high-risk occupations or other risk factors, do we consider switching them to a medication that has less risk of elevating their risk for heat-related illness? These are questions that we don't necessarily have the answers to yet, and there's some early evidence to suggest some of those things. But in my emergency medicine mindset, you take what you know and you start to implement some of these treatments, evaluate them very quickly, and iteratively adapt them. And then, of course, we think about infrastructure, power, and supply chains. I don't know, we experience shortages of saline, which is water in a bag, if you think about all the things to be lacking following Hurricane Maria, because more than 50% of the saline is produced there. And so I was actually handing out cans of Gatorade in my emergency department. And so how do we think about those medications and supplies that are most at risk, as we saw sort of unfold even with the supply chain disruptions from the pandemic, in order to build in that infrastructure to be resilient when extreme weather hits? Now, I could probably, again, give a whole lecture on just this slide and talking through the different ideas, but it's meant to be a thought exercise for you to start to apply that to your own practice. And if you want to dive into some more thoughts, at least around that patient that I talked about, and thinking about how to add a climate lens when we think about extreme heat in the emergency department at MGH or within Greater Boston, there are some sort of aspects outlined in a perspective in 2020. Now, acknowledging the need that I outlined, that we have to accelerate our understanding of climate-informed clinical practice, we hosted a symposium in Boston in February of 2020. And that brought together all hospitals in Greater Boston to really talk about how is this impacting our clinical practice and our ability to deliver high-quality care. That has led then to an initiative that unfolded during a pandemic. As you know, let me just say the date here, February 13th of 2020. We had no idea what was around the corner, but arguably that has changed timelines. But amazingly, we still have had amazing partners, including Emory and Atlanta, which actually hosted a climate change and clinical practice symposium in, it looks like April 28th of 2021. So thank you if there's anyone on here who participated or helped foster that. That was a critical conversation that happened. And there was also ones in Cleveland, Northern California, and there's actually a forthcoming one in Seattle, Washington. And we've had partner events in Tampa and New York City for them to bring together their local healthcare infrastructure with which to have conversations about how we work together collaboratively, because fossil fuel pollution and climate change does not end when where our hospital ends, just like the pandemic and didn't end at our hospital boundaries. So, all right, so that was, again, just to really provide some thought-provoking. Again, I did task you with trying to find one aspect, so I want to just sort of cover the gamut of some others to think about. And so we have to think about this, and at least I think about this in downstream and upstream action. And so we talked about sort of how do we adapt our clinical practice and sort of the concept of healthcare system resiliency. We also think about how to develop climate-informed education, and I think there's been a whole movement around that is accelerating, which is fantastic, to make sure, as that editorial in New England Journal said, that we can develop clinical practice that is climate-informed for the 21st century. And so that includes not only practicing physicians, but for those that are in training, whether residency and fellowship, but also medical education. And the climate lens concept works there too. So I recognize people are like, how do I add a whole other slide and a whole other topic? But it's as you teach the things you already teach, how can you think about these upstream impacts and threats harming that condition? So thinking about my patient with asthma. So developing additional learning objectives or a few extra slides, because that is how we have to think about it in practice, and it actually plays out. Research, as I said, we don't have the research dollars that we need right now in order to mobilize at a COVID-like scale yet. And that's the key word, yet. So we need to mobilize our existing research infrastructure. And so for those of you who are researchers and have existing programs, how can you add a climate lens to what you already study? So adding a specific objective or specific aim, to your existing grants to begin to understand how these different exposure pathways or compounding insults impact whatever it is that you study. Even if you study something like oncology and specialized care, how do you ensure that your patients can get to the hospital to get that? And of course, we have to work closely with our public health colleagues. We are all operating on the same river, so any dam we put there is artificial. And so those population and community level interventions are critical for us. And we need to accelerate that coordination and collaboration between our infrastructure. And then ultimately, we need mitigation. We have to get to that upstream root cause. And so the prescription that we need to write our patients, and what I couldn't write my patient, but ultimately what she needed, was to end fossil fuel extraction and to have a rapid transition to renewable non-combustion energy. Of course, in the interim, she needed air filtration systems and being able to know when and how to check pollen levels and pollution levels outside, making sure that the home weatherization and heat pump is installed with an air filtration system to keep health protective cooling, while also ensuring that the air that she can breathe at home is clean, while we work to transition electric vehicles to the highway that is next to her house. So in closing, and I recognize we only have a couple minutes for questions, but I do just view this as the start of a conversation, is I oftentimes think about that mother's plea. So thinking about what resonates both in my ears and my heart is that she says, what am I missing? And so I challenge you to think about what is it that you're missing that perhaps now you can incorporate a small intervention or perhaps a really big intervention and work collaboratively with the growing effort for us to address this. So we're not recreating wheels, but we in fact are linking together, quickly sharing what's working and what's not, so we can protect our patients and leverage our unparalleled platform to make the what's at stake very clear for people. We need a transition away from renewable energy, and it is fundamental to everything that we do in medicine. So I hope we've covered some of the learning objectives here and that you've walked away with some greater understanding, if not at just a high level. And again, I view this as just the start of a conversation. It's been an honor and privilege to spend time with you. Thank you to each and every one of you. We all have a role to play, and I look forward to working with each of you. Thank you so much.
Thank you so much. That was fantastic. Please feel free to put questions in the chat or to raise your hand if you're in a location where you can talk. I'll just shout out to our medical students who actually started a climate change curriculum and have actually passed it through the school and have had all of us embed slides on climate change into all of our modules, and they've really been fantastic. We also have programs within residency that are focused on climate change education and so on. And one of those is headed up by Mehul Tejani. Mehul, are you in a position where you can unmute to ask your question, or do you want me to read it?
No, I'm here. Thanks for letting me do that. Hello, Renee. Good to see you again. I did have one question, which is actually I have two. The first one is for the slide comparing the South to the West. Do you think a lot of that has to do with physiologic changes that are happening to people that live in warmer climates, or is it more due to the infrastructure that we have built in terms of access to air conditioning or whatnot?
Yeah, it's a great question. And I think, as always in emergency medicine, I love to bring in a host of consultants on cases who are experts within that area. So I'm always the first to say I'm not a heat physiologist, if I can even say the word, heat physiologist. And so my sense, based off my work in this field, is that I think it's probably driven more by infrastructure, especially when you look at air conditioner penetrance, which again is the predominant way with which we cool our homes. Arguably, it's maladaptive because if it's drawing from fossil fuel energy, then it is actually worsening air pollution, worsening climate change. And it also produces kind of increased heat around that locally, which is just worsening sort of the heat we're trying to protect ourselves from. So heat pumps arguably are a more sustainable option, and I think we need to think outside the box about what needs to be done. But anyways, my quick side rant there, not related, but I want to say that my sense is probably more infrastructure and then probably behavioral. I think if you look at, for example, the Pacific Northwest heat wave, which was unprecedented and actually would have been impossible without climate change, with attribution studies have shown, and led to record ED volumes and deaths, that a lot of that seemed to be people were behaving under recognizing, I think, the harms of heat. And again, if you're not in it, you don't necessarily always know what you should or shouldn't do or what some of the warning signs are. So I think there's behavior and educational opportunities. And then my guess is sort of physiology probably comes in third, but again, that is one of these, and I would defer to colleagues who specialize in that.
Preeti, I see your hand raised.
Yes, thanks. I just wanted to put a plug in for Georgia Clinicians for Climate Action, which you can do a lot of advocacy in our state. We advocate for electric school buses. We have a Georgia Drawdown grant for that. We're also advocating for clean energy in our state. And I put in a link for everyone that everyone could do it today, just putting opposing new fossil fuel infrastructure that's being planned in our state. So please feel free to reach out to me, because we have a lot of organized advocacy campaigns, and our voice is really, really important. At the Public Service Commission a week or two ago, we about 8 of us clinicians were speaking about everything from infectious diseases to climate anxiety to other effects of climate change on health. And I think it really makes a big, big difference when clinicians get involved in advocacy.
Yeah, thank you for all your work. That's amazing.
I agree. We're at the top of the hour. I'm going to ask you one quick question. You know, you made the point about research, which often drives pilot studies, which then drive, policy change and so on. Is your sense that the NIH is receptive to increasing funding for climate change, or do you feel like there's another federal agency that may pick this up? But, do you see a world of more funding for clinical, in medicine and climate change?
Yes, I have to envision that world. And I think that we together can create that. I think when voices are loud enough, and especially when we show that, again, climate change is that meta problem and threat multiplier, touches everything that people already study and are funded for at the NIH, then that makes that even more of an imperative. I think that the will and the desire within the agencies themselves is there. I mean, they've been asking for funds. I think, unfortunately, if you look at what the budget appropriations have been and what's been put forth as the ask and what actually is delivered, there is a stark contrast between those two. And so I think that points to two things. I think one, the importance of what unfolds at the federal level in the coming year, and sort of where we'll be in January of 2025. Crazy to say 2025 now. And so the importance of getting out to vote. And I think secondly, also recognizing that we want to accelerate those funds, but we also have to recognize that we have to build infrastructure around that, that's outside of that federal government in order to help catalyze that and augment and make sure that we can help raise our voices for the money that's needed to do what we need to do to take care of our patients and protect our health systems.
Well, on that note, thank you so much for taking your time to deliver this talk to us. I think we all learned something and feel a little bit more wind in our sails to make a difference. So thanks.
Yeah, we'll achieve this by working together. So I look forward to that unfolding. Thank you so much for having me.